same thing. And one of those would be something like Master's disease, which Ed Masters made famous down in the South, that is caused by Borrelia bone starving. So other infections spread by these same ticks, I apologize for multitasking, include anaplasma and ehrlichia, which are related bacteria, and they cause the syndrome of ehrlichiosis, which is typically manifest as a high fever and diffuse body aches and headaches and such, with elevated liver functions and low platelets and low white count. And I always tell people, to have choose one tick-borne illness, choose ehrlichiosis, because it either is asymptomatic or very severe, and you get rid of it, it doesn't have the propensity for chronic infection, whereas Lyme does, and so do the strains of Bartonella. Bartonella is kind of weird because at least everybody's fighting about Lyme. Nobody really mentions Bartonella. Bartonella, there's a lot of strain heterogeneity. There's over 25 strains that we know of, and we only have a test for 2. And some people with normal immune systems get very sick from it, and most people fight it off on their own. When people do get sick from Bartonella, it's harder actually to treat than Lyme. It's more drug resistant, requires somewhat different antibiotics. So if it's okay, I'll constantly babesiosis, of course, and the 2 major strains around here are Microti and Duncani, which is Babesia-1. And so in order of propensity for chronic infection is Lyme and Bartonella, which set up the most chronic infection, and then Babesia, and then toward the last is Ehrlichia and anaplasma, which are usually treated. So I'll concentrate on the evidence that documents chronic infection and chronic Lyme disease, because there are 2 standards of care that currently exist. And when they've done studies to look at how long people, regular general physicians are treating Lyme disease, I think I should do this slideshow. Sorry. Lyme endemic areas, they've come to the conclusion that 43% of these general physicians treat for disseminated Lyme, they treat for more than 3 months. And for chronic Lyme, the majority treat for more than 3 months. Yet, some doctors make out as if nobody treats for long-term Lyme apart from Lyme doctors. Just that general physicians don't like to talk about it because nobody wants to be known as a Lyme doctor. So when doctors and lawyers have gotten together and written articles about this and done a medical legal assessment, they said that there are 2 equally divergent but completely different standards of care for treating Lyme. And they have equal legitimacy, but they're diametrically opposed. So this is best represented by 2 medical societies, and one is ILADS, which is International Lyme Associated Diseases Society, and the other is IDSA. So ILADS basically says that, bad cases of Lyme are serious. They have to be treated with antibiotics promptly, and aggressive antibiotics, even long-term, may be necessary. IDSA says there's no evidence that persistent infection exists after people take a standard course of antibiotics. And by that, they mean a short course, typically 1 month in length. And they say that antibiotic therapy doesn't help. It's not proven to help these people with chronic symptoms after Lyme disease. So here I'll go for the evidence at first, showing chronicity of Lyme. So first I want to point out the name in green. On the bottom there is Dr. Steer. Whenever you see a name in green, that's one of the Infectious Disease Society of America's guidelines authors, because this is actually his own study. So back in 1994, in the New England Journal of Medicine, we did a study of patients who were treated for different lengths of time and looked for Lyme DNA in their joint fluid. And they found that if they took less than 1 month of oral antibiotics, 100% they found the DNA of Lyme. If they took 1 to 2 months of orals or antibiotics IV for 3 weeks, at 37% they found the DNA of Lyme. And when people took multiple courses of antibiotics, they found it in 30%. So roughly 1/3 of people, despite multiple courses of antibiotics. They didn't specify what multiple courses of antibiotics were, how long it was, but the indication is that it was longer than the 2-month period for group 2. And Dr. Steer says, quote, that the detection of outer surface protein A DNA, which is this DNA from Lyme, in these joint fluid samples indicates the presence of viable spirochetes. So back then, in '94, he was saying that, boy, chronic Lyme exists, that is chronic infection. And that was a long time ago. and yet the debate still rages on, whereas one of the IDSA guidelines authors kind of proved it way back then. And here, in this study of long-term patients who were treated with standard therapy, which is again a short course of approximately 3 to 4 weeks of antibiotics, they found that 26% of them relapsed by 1 year and required retreatment, and 34% of them had long-term symptoms. And one of the patients in the study, one of the 38, ended up passing away from her Lyme disease, which had developed into hardcore neurologic features, and despite being treated with a total of 4 weeks of IV, which these folks would kind of make the claim that these are curative therapies for Lyme. So when she did pass away, they did an autopsy, and in her brain they found spirochetes. So although this study was cited by the IDSA guidelines, this pertinent finding was omitted, just like the study before. And this study also by Dr. Steer, they had 12 patients who failed antibiotics, and they found spirochetes that were alive in the joint tissue of half of them. And he makes the statement that the stimulus for Lyme arthritis is a small number of live spirochetes that stay alive for years. In the next study, again by Dr. Steer, IDSA guidelines author, he took a person who had passed away from pulmonary failure, which they attributed to Lyme. In retrospect, this was in 1988. We didn't really know about Babesia back then. It's unlikely that it was single-agent Lyme that would cause an ARDS, adult respiratory distress syndrome. It's probably that the person had a co-infection that was causing an inflammatory response and the pulmonary failure. Nonetheless, after about a month of antibiotics total inclusive of IV, she passed away and they found Lyme with autopsy in the lymph nodes. And then in this study, an American patient, a young woman had a Lyme rash after she went camping, and then years later developed severe arthritis that was so bad that she needed multiple surgeries. And finally she had a positive Lyme test and said, aha, your arthritis is from Lyme. And she ended up getting 2 courses of IV penicillin, 3 courses of IV ceftriaxone, which is Rocephin, and 1 course of intramuscular penicillin, and all of it helped, but she kept relapsing. And then she did doxycycline for over a year, which didn't help, and sulfasalazine, which is an immunosuppressant, for about a year, and that didn't help either. And despite all those antibiotics and all those relapses after therapy and responses to therapy, the joint tissue and joint fluid revealed spirochetes that were alive, and the DNA identified them as Lyme spirochetes. And in this study and I won't present too many studies, and it's boring, I just want to make a point. I'm going to present in total 25 studies, but only go over maybe, 6 of them in detail like this, because people say it's so boring. So, I do get that a lot. So, anyway, this is 7 Lyme patients with not just neurologic, but urology symptoms, and they were treated with an average of 3 weeks of IV ceftriaxone. 57% relapsed despite treatment, and the antibiotics were helpful in all patients, but despite the antibiotics, 71% remained symptomatic. Again, underlying this theme that the antibiotics help, but they're not magic, and they don't cure a lot of people. In one of the patients, despite 3 weeks of ceftriaxone, they did find Lyme butyrate alive in the bladder biopsy and was confirmed with monoclonal antibodies. In this slide, this is interesting because, and I'll tell you why it's interesting afterwards. This is a woman that didn't have a history of a tick bite or a Lyme rash. She never had a positive blood test for Lyme. She never had a positive antibody test for Lyme and spinal fluid. Yet, look at all the treatments she had. 7 rounds of IV antibiotics and 3 years of continuous oral antibiotics. And the only positive tests she had, which were 43% of the time, they were negative, so roughly half and half. Her spinal taps were positive by some research tests. So these 2 tests, the immune complex test and the outer surface protein A free antigen, are not commercially available, and the PCR is commercially available, but it was really hit and miss with any positive testing on this woman. Yet she had all this very intensive therapy. She would get severe Herxheimer's upon reinitiation of each antibiotic therapy. And when I say severe, I'm talking severe enough that she would be semi-comatose and paralyzed on one side of her body, and they couldn't prevent the Herxheimer's. The reason I say it's interesting is because one of the authors is Patricia Coyle, who's a physician from Stony Brook, and she was one of the authors of a prior IDSA guidelines. And I always wondered, why would Patricia Coyle be involved in a case where they would treat somebody with negative blood tests for Lyme and no Lyme rash and no nothing, except for a couple of research tests showing positive on the spinal fluid with such long antibiotics? The patient in the study, it turns out, is a physician. And this is typical about how doctors treat themselves and get treated when they have Lyme. So there's a very big discrepancy. When a doctor gets Lyme disease, they generally do much better than the patients because they treat themselves longer and more aggressively. And I have to tell you that I have over 100 patients who are physicians who I've seen since 1996, and only 3 or 4 will treat Lyme disease, despite the fact that they have chronic Lyme themselves. I think that's a very compelling commentary on the situation, just politically and honestly. I like this study because they did brain biopsies on patients, and you don't do that very often. This study, the first patient had a negative blood test, a negative spinal fluid antibody test, and no white cells in the spinal fluid, and they cultured Lyme from the spinal fluid despite completely negative tests. So they treated the patient with 3 weeks of IV ceftriaxone, partially improved, and then long-term doxycycline for 8 months, but the patient relapsed. The Lyme DNA, the PCR, which stands again for polymerase chain reaction, it's a method of amplifying DNA for Lyme, was positive in both the plasma, which is part of the blood, and the bone marrow. So after that, there was still evidence of Lyme, and the patient passed away, despite having restarted the ceftriaxone. And then on autopsy, they found Lyme in the brain as PCR positive. Patient number 2, the person had a short window of an IgM positive Lyme antibody test, and then it went negative, and the IgG never went positive. And the disease progressed despite the antibodies never turning positive thereafter, just completely negative. And the spinal fluid was always negative for antibody and PCR. And without doing these brain biopsies, the person really couldn't have been diagnosed by a laboratory measure. So you would say, what's worse than 1 brain biopsy? 3 brain biopsies, right? It was positive in 3 separate samples. So this person failed 7 weeks of ceftriaxone and almost 9 months of really intensive oral antibiotics. And after stopping the antibiotics, there would be relapses and more brain lesions. And it was a very difficult course, and the Lyme DNA and PCR were positive again in the plasma. So the person was finally treated with 3.5 months of ceftriaxone, all the brain lesions resolved, and the patient remained well on long-term follow-up. So it's a happy ending. This is a good study because it's a large study. There's 165 patients, and all of them met the strictest CDC criteria for entry. And they're treated for a long time. They're treated for 4 months on average. And despite that, 19% still relapsed. And of those people who relapsed, 41% had evidence of persistent Lyme, either culture, PCR, or both. And 85% of them had received IV ceftriaxone as part of the treatment. So all the patients were retreated, and 69% of them retreated patients responded again to antibiotics. Here I'm just going to just quickly say here's 5 more studies. One of them I point out is IDSA guidelines, all in green, which document persistent infection despite either recommended and or long-term antibiotic therapy. That means at least 3 weeks of antibiotics, up to years of antibiotics. And again, by culture and or PCR, but primarily culture. So it's 5 studies, 5 more, and 6 more. So this is a total of 25 studies that I just presented by the most accurate laboratory measures that we have available in all clinical science to document persistent infection. And despite that, despite the fact that roughly 25% of those studies were written by IDSA guidelines authors, they still say there's no convincing biologic evidence for the symptomatic chronic deep dry infection among patients after recommended standard treatments. So it's one thing to say, I'm not aware of the data, I didn't know. It's another thing when you wrote it yourself. So, but the other part of this recommendation is that they say that antibiotic therapy has not been proven to be useful, and it's not recommended for patients with subjective symptoms. So let me just go over subjective versus objective. Subjective is when the patient has a symptom that the doctor can't see, and objective is when the doctor can see it. And so here is a study of early Lyme. They looked at what's objective and what's subjective. So in these patients with Lyme rashes, which is technically an objective feature, but that was the entry criteria, so we can't ignore that, they didn't have objective features. They didn't have AV block, which is a slowing of the heart rhythm. They didn't have meningitis. They didn't have Bell's palsy, and they didn't have lesions in the brain and spinal cord. That's what the key Lyme. Only 10.8% had anything that was objective apart from the rash, and that's a low number. So what happens to the people who don't get the rash? A lot of people don't get the rash with Lyme. So what objective features? How do you diagnose early Lyme? Well, subjective features predominate. They were tired. They had body aches. They had headaches and chills and joint pain without swelling. All the things you report to the doctor and say, I feel this way. But the IDSA is not recommending that doctors take that seriously. These patients who are subjective, we're not supposed to treat them. We're only supposed to treat what we see. And what about late Lyme? What's the ratio of objectives to subjective features? Just like early Lyme is frequently diagnosed with an objective feature, irritative migraines, the rash, late Lyme is frequently diagnosed with big arthritis or encephalomyelitis and brain lesions or something else that's subjective. When you remove these objective features from the diagnostic criteria for late Lyme disease, then you get a different picture. So, oops, I went ahead of myself. I'll go back. Here in this study, they did just that. They said, we're not going to diagnose late Lyme by any objective features. We're going to diagnose it by the presence of the organism. So they took patients, 18 of them with failed antibiotics, were still symptomatic, and in all of them they found evidence of Lyme still in the body with electron microscopy or PCR. And they found that not only were 39% initially blood test negative, and then 2/3 of them were blood test negative later on in the illness, but that the rate of subjective features only, they call it non-specific features in the study, they mean subjective, is very high. It's 50% initially, and with later illness, it gets higher to 2/3. So I'll just go back over here. So it shouldn't be a surprise to any of these folks, and again, Steer is highlighted here, that subjective features are common with Lyme, because in the vaccine study, number one, they found that 11% of people converted asymptomatically to 5-band IgG criteria, which is the CDC reporting criteria, which is a very difficult criteria, as some people in this room I'm sure know, to meet. And the 11% of them did. They did so in an asymptomatic fashion. So if you can have asymptomatic Lyme, clearly you can have Lyme without a big swollen joint. And then in a serious study, they found that 16% had only subjective symptoms. So if you combine that together, they had 27% of people infected with Lyme without objective features. So what I'm trying to say in a nutshell is that there's good evidence in both early and late Lyme that subjective features predominates over objective features in Lyme disease. So if we take the advice of the IDSA, we won't be treating anybody, because that's basically who we see. The people mostly have, the people look pretty good. So then the third part of this recommendation is that antibiotics have not been proven to be useful. So we'll analyze the studies that look at antibiotic retreatment of chronic Lyme. There were 4 NIH-sponsored randomized controlled trials to retreat chronic Lyme patients with antibiotics, and 2 of them demonstrated benefits, and 2 did not. The 2 that did not, I'll address in the next slide, and they're part of one study that they divided up into 2 trials. And then there were 3 open-label trials, which are not randomized controlled, which means they don't have a placebo arm. They just gave patients the antibiotics, and they kind of showed benefits. So there are other studies besides this, but it's too much time to go over all of them. But in the first 2 studies, I'm going to analyze them one by one. Here, I was one of the authors on a paper that statistically analyzed all of these 4 studies to see which were valid and which weren't, and how were they valid and how were they not. So in the first 2 studies, which again is represented by that one paper, and Pfeiffer is an author on the IDSA guidelines, it turns out that their statistics were highly flawed. And we published our paper in Contemporary Clinical Trials, which is a really good statistical medical journal. We found that in order for them to have detected a benefit from antibiotics, it was designed so that statistically the Lyme treatment group would have had to improve to a level of health that was a full standard deviation superior to that of the general healthy population in order for them to detect a benefit. So if you design a study like that, it's an unreasonable expectation. Antibiotics are not going to help you to play the piano, you can't play the piano, and they won't make people healthier than the average person. You can only reasonably expect them to bring them up toward the level of general health, and not superior to that. In the crop study, they had 3 outcomes that they were looking for, and it was only appropriately powered for 1, which was the fatigue outcome. And sure enough, that outcome was the one that they showed a benefit to fatigue. And then in the balance study, it was appropriately designed for cognitive, to detect changes in cognition, and they did. They showed that there were cognitive benefits, but they were unsustained. So after antibiotics, they got better, and when they stopped them, they got worse, which is what the patients keep telling the doctors. And then on reanalysis with subgroups, they found that fatigue and body pain also improved after antibiotics in the common study. So my conclusions from looking at all this is that there is evidence, there's lots of evidence that DWR persists after a short course of antibiotics, and I think that the oversights by the IDSA guidelines, I like to use the word egregious because it sounds big, but it really is, it sums it up. I think it's an inexcusable kind of situation. I can't fathom how this is something that currently exists in practicing physicians, but it's the way it is. And I don't tell people, people come all the time to say, my doctor doesn't believe in Lyme. I say, it's not a religion. The facts are the facts. Either we choose to ignore the facts or we choose to accept the facts. But you can't change, the truth. You just have to look where it is. So, all right, so here I'd like to, if it's okay, go over a few cases, because this will help to kind of, I think, pull everything together, and maybe, people really like to know how you treat Lyme, how do you know what people have, whether it's Lyme or Bartonella or whatever. So here's the case. I don't usually see children, but they called me up, and the parents really begged me to, it's a very nice family, so I said yes. I see down to 16 with both parents, but I slowed down to 15 this time, because this is her story. She had very typical Lyme arthritis. It wasn't controversial at all. She's from a highly endemic area in Massachusetts. For Lyme disease, she had CDC positive ELISA, and almost all bands in the Western blot, and she had a big swollen knee. She had the very stereotype of Lyme arthritis, and she was treated with doxycycline, and it helped. And when she went off the doxycycline, it came back. And the doctor said there's nothing more that we can do. The only option you have is surgery. So they took out the joint tissue on a 15-year-old girl, who was an athletic girl, and it didn't help. And the parents were desperate. They went back to the physician, and they said, is there anything? They went from doctor to doctor. The only infectious disease doctor said, well, I guess it's possible we could treat you with Rocephin, which is the intravenous antibiotic. So they gave her a month of Rocephin, and it did help. And she was about 90–95% better with the knee arthritis, about 8 months. And then she played sports and did fun things, and it was a pretty normal life. She got appendicitis and had just a day of antibiotics during the acute appendicitis, and that 1 day of antibiotics started the whole cycle all over again, and her arthritis came back. So she went back to the doctors and said, now your only option is methotrexate, which is a chemotherapy drug to destroy the immune system. So the parents were horrified, and they said, well, let me take you to the doctor. So they went to a rheumatologist, one of the IDSA rheumatologists, and he concurred. He said, methotrexate is the most appropriate option. So rather than, she has a history of responding twice to antibiotics. It's not like the antibiotics didn't work, So the reason I bring this up is this didn't happen 15 years ago. This happened 3 months ago. And this is the standard that still exists in Massachusetts. So if you think it's bad here, just be thankful you live in Connecticut, because Massachusetts is even worse. And so what I treat her with, the usual. We'll start with tetracycline. I did a month of that, and she got some partial improvements. Physical therapy said that her range of motion was improving, and she switched over to Viaxin and Plaquenil. People like, what's Plaquenil? But Viaxin. Viaxin is a common antibiotic that's used for bronchitis, and, upper respiratory infections and such. Plaquenil is an anti-malarial antibiotic that rheumatologists have used for various forms of arthritis, and they've used it for many, many decades without ever knowing how it works. So, most people probably know that Lyme was first thought to be rheumatoid arthritis a long time ago. Lyme has had its hooks in rheumatic disease since the very beginning of Lyme disease. And it's like one big Venn diagram. People frequently tell me, well, which is it? Do I have Lyme or do I have rheumatoid arthritis? And and say yes. Okay? So it's like saying, do you live in Wilton? Do you live in Connecticut? You know, they're not mutually exclusive. So rheumatoid arthritis is a descriptive diagnosis. Lyme disease is an infectious disease diagnosis. All the rheumatology diagnoses are descriptive. It may be that there are 4 causes of rheumatoid arthritis, or 14. Maybe the Lyme is one of them. Maybe these other infections like Bartonella is one of them. I personally believe that Bartonella type infections are much more common in inflammatory arthritis than Lyme actually. So for hardcore inflammatory arthritis, I frequently suspect Bartonella more than Lyme. So Plaquenil has been published to kill cystic forms of Lyme. And cystic forms have since changed the name to round bodies. And there are these kind of resistant forms of the organism that start to convert after about 6 weeks of exposure to antibodies in the blood. And they will convert in response to antibiotics. They're a protective form. And there are 4 antibiotics, well, there are 3 that are published to kill cystic forms. And there's Flagyl, Tindimex, and Plaquenil. And Plaquenil, again, is an antimalarial antibiotic. So Plaquenil, I think, works in 3 ways. It works because it has a small anti-inflammatory effect. It works by killing Lyme round bodies or cystic forms. And it also synergizes with macrolides because it stabilizes them inside lysosomes, which are acid-containing compartments in the cell. It neutralizes the acid, and then the macrolide antibiotics like Dioxin and Zithromax don't get destroyed as much. So anyway, I just figured I'd elaborate on just one of these cases. And then the next case. So this young lady came to see me from Pennsylvania, and I just saw her yesterday. I told her I'd like to present the case, and she said, absolutely, please do. I want everyone to learn. It's okay. So a few years ago, she had mild arthritis, it was really nothing, and a tiny bit of psoriasis. And she was diagnosed with psoriatic arthritis. She was running half marathons, and she was literally fine. And then in the summer of 2013, she got a really high fever, 105. She got really bad arthritis. Her foot blew up like the size of a football, and she had a positive Lyme test. And the doctor was like, this is clearly Lyme, and treated her with doxycycline. During the doxycycline, she got the new onset of atrial ventricular block, AV block, which is slowing electricity through the heart. So sometimes when you treat, even objective things pop up. Everybody knows about the subjective stuff that pops up during treatment, hurt sound reactions, that people feel like garbage. But sometimes people get Bell's palsy, sometimes arthritis gets more inflamed, and you can see it. Sometimes things, and sometimes things like I said, like the AV block will show up, which did with her. And then they got nervous that she had an objective feature in addition to the arthritis, so they started on Rocephin. And the AV block went away, but the arthritis didn't just not go away, it progressed. It continued to get worse and worse. By the time she came to see me, she barely walked, and her foot was like this. And her toes were like sausage digits. It was like typical psoriatic arthritis, as it's described. And her CRP was 30. CRP is a C-reactive protein. It's a measure of inflammation. And I was suspicious about Bartonella because of the failure of the Rocephin and the high level of inflammation and her inflammatory arthritis and her prior psoriatic history. So I started doxycycline as the first thing, and brucellosis antibody test came back for one. So brucella, I didn't talk about yet, is the most common zoonotic infection in the world. It's prevalent everywhere except for here. In the United States, they say it's 1 out of 3 million to get it in the United States. So I have 6 patients that I diagnosed in the last 6 months with brucellosis. And I didn't send them out anywhere. I didn't send them to fancy labs. We're talking Quest and LabCorp. And I don't know that she has brucella or not, to be honest. She could have just a bad Bartonella that's cross-reacting. So brucella and Bartonella are, evolutionary-wise, they are related. So they are close cousins. I think it's possible that she was having nasty Bartonella that's cross-reacting with brucella. But they're treated the same way. And, I treated her with a combination of doxycycline, rifampin, and Bactrim, and she had really prompt resolution of her arthritis. She felt great, and her CRP went to 1.8 within 2 months, and she was doing quite well. And coincidentally, the psoriasis that she had for 3 years, which never really bothered her all that much, but she had for 3 years, just gone, went away. So the reason she came back to see me is she went and she followed up, now that everything's under control, she followed up with a local doctor who she thought would be able to take care of her, and it was kind of a mess, and without going into details, so she came back here after a few months of spiraling down and relapsing. So that's her story. So you say, well, is there an typically Bartonella and Brucella, are arthritis type, are a arthritis-producing bacteria that will focus on the swine. So in the next study, they showed that rifampin reduced psoriasis with a very high statistical probability. So that p-value, if there are any statisticians in the crowd, of 0.0008 is extremely low. That means that the odds of rifampin helping psoriasis by chance would be like a little less than 1 out of 1,000. And then they also showed that Bactrim, a review article which references multiple studies, showed that Bactrim works for rheumatoid arthritis. So you figure, why don't rheumatologists use antibiotics more often if there's all this data showing that it works for inflammatory arthritis? I don't know the answer, really, but I do know that that every time I see a commercial on television for an immunosuppressive drug, it's like every other commercial is an immunosuppressive drug for rheumatoid arthritis. I know they're quite expensive. So here's a patient who had a very common Lyme presentation, and probably the most common kind of alternate diagnosis for Lyme is fibromyalgia. Fibromyalgia is kind of a vague diagnosis. It's a lot of the symptoms of Lyme is fatigue and headaches and muscle pain and sleep disturbance and mild cognitive deficits, and everything's on this Lyme symptom checklist. They keep expanding the checklist for fibromyalgia. It includes like everything with Lyme. And they've done studies with patients with fibromyalgia after well-documented Lyme, and they have found Lyme DNA in the muscles of these patients, but I digress. So this person had a history of 3 years of sleep disturbance, followed by 1 year of joint muscle pain. Then she started getting weakness and started dropping things.